Hey guys, coming to you from beautiful Germany, a little city called Ulm in Bavaria, gorgeous place. I'm going to talk today about pain management and how pain management works when you mix it with addiction. Do patients who have addictions, do they deserve pain management, for example? Or should we just let you suffer and sit in agony, as seems to happen a lot? I see it a lot in patients who come in from the emergency room who have been blown off for their kidney stones or broken bones or whatever, and the ER doc will tell me, well, they're already getting methadone or Suboxone. We can't possibly do pain medications because they're an addict, and so therefore we can't do that, which of course you guys all hopefully understand is not proper, not ethical, and medically not viable. Patients with addictions still deserve pain management, right? I think that's a basic tenet of being a human. You just have to do it properly. Of course, we should have been doing pain management properly from the get-go. That don't understand that just because you have a history of addiction doesn't mean that you don't deserve pain management. So how do we do that when you're on Suboxone? How do we do it when you're on methadone? Well, for one, we recognize that the opioid receptor is blocked by the medication, by the methadone, by the Suboxone. It's basically jammed up. A lot of ER docs will say, well, how do you get extra pain control with oxycodone or Vicodin when you've already got the receptors jammed up with Suboxone or methadone? The answer is simple. Those medications work on other receptors, not just the mu receptor. There are other narcotic receptors like kappa receptor, delta receptor, that oxycodone and Vicodin and tramadol, Nucynta is another good one, can work on and effectively block pain, and at the same time not give you that euphoric high while you are on lockdown with Suboxone. So Suboxone will basically latch onto your receptors very tightly, and to a certain degree it will block a little bit of a breakthrough oxycodone. So if you go to the ER for kidney stones, for example, what you need to do is you need to tell them, hey, I'm on Suboxone or methadone. Number one, for my patients personally, they are told to tell the ER doc to never give you pain management, okay? All the pain management comes from me. The reason I want all the pain management done through me is because I want to be the one who's in control of monitoring, managing, and dispensing the proper pain meds to the proper patients in the proper amounts for the proper duration. What is the proper duration for something? Well, like for example, kidney stones, you don't need 2 weeks worth of pain medicine, but maybe 3 or 4 days at a time. It's always easy to refill this stuff. So my preference is always do lower amounts, refill it when you need to, follow up with the patient appropriately. You can always do a few days more. So back to why would oxycodone and Vicodin help give you pain control if you're already on Suboxone and your brain is somewhat locked down? Well, again, those medications will work on other receptors like the kappa, the delta receptor, and give you analgesia, pain control, even though the mu receptor itself is, for the most part, locked. Suboxone is a partial agonist, not a full agonist. So that means it will block, but not completely, okay? You will still get breakthrough. A 10 milligram Vicodin pill will get blocked a little bit, so we have to keep that in mind and sometimes do a couple of milligrams extra. That's my job to figure out the dose. But in a sense, sometimes the 10 milligrams will actually appear to work more like a 7 milligram or 6 milligram, something like that. Either way, that's my job to figure out. Your job is to always report when you do need something, when you're in the ER. We have that contract / agreement that says, I don't want you getting pain meds from anybody else. Allow me to do that for you. If you have a root canal or a dental abscess, I will call the dentist myself just to confirm it's good communication, it's the proper way to do it. The dentist will say, yeah, it's legit. He's got a big old abscess. We're going to rip out his tooth in a couple of days. Then we'll talk about what's reasonable pain management. And then I will prescribe that for you. One of the reasons I like to be in control of the prescription of the medications is that I am a little bit more aware of what the problem medications have been for you in the past. So for example, if you have had a history of abusing oxycodone, for example, then one very wise strategy would be not to necessarily use oxycodone as your breakthrough pain control for your broken arm or your root canal, okay? It might be wiser to do a different opiate so that you have less triggering, less kindling. Something like Vicodin maybe, something like Tramadol maybe, you know? Nucynta. Nucynta is a very good pain management tool that plays very well with a lot of the other medications. So that's the reason why. A lot of times the dentist or the ER doc will simply dispense whatever is easy, whatever is simple, whatever they're used to, you know. It might be oxy or whatever. And they'll do it randomly. They'll sometimes say, well, I just hand out a script of 30 pills and that needs to last. That's not necessarily the best way to do that, is it? It's really probably better to be very specific about how bad of a root canal is it? How bad of an abscess is it? Or a fracture? Is it a twisted ankle? Or is it a huge break that requires screws and plates? For the most part, we really should try to do like 3 days at a time, small doses. It's better for us to be in communication and to refill more frequently. I will never withhold proper pain management for patients who need it and deserve it, even if there is a history of addiction, because that's unethical. We just have to do it properly. And if something lasts for a long time, you have a hip replacement, 3 days is not going to do it. But sometimes I'll start with 3 days, and then I'll extend it for another 3 or 5 days. And then depending on how you're doing, we'll go from there. Sometimes it's really helpful to have spouses at home that can help monitor taking those meds, you know. We don't overuse them. We don't use them for other purposes. So you come in for a broken arm, I'll give you some pain management for the broken arm. All of a sudden you need a root canal. Guess what? We don't use the medications that were earmarked for one problem for a different problem. Everything has its own place. Everything stays separate. Nothing is ever mixed. And nothing is ever crossed over to other problems, okay? Even if it sounds legitimate, like, well, it was for my root canal, but now I have a broken finger. You don't use that. You can't use it for that, not unless it's gone through me. I am the gatekeeper, and there's a good purpose for that. It's not that we're trying to be punitive by monitoring you guys that closely, but it's in your own best interest to be monitored. And you guys know that. Most people realize that the best care is when you're being monitored properly. I don't care if it's diabetes, addiction, pain management. It's always the same. People that are more closely monitored generally have better outcomes. That's the truth of it. Some people ask, hey, what's going to happen if I fall off my mountain bike and I'm unconscious and the ambulance takes me to a hospital with a broken femur? You know what? In that case, the ER doc will do whatever they need to do. They'll use IV pain medicines like Dilaudid, whatever it takes to get the job done. That's what they'll do. And there's no problem with that. Then afterwards, they'll call me. Somehow we'll communicate. But the important thing is you will not be left out in the cold. You will not be left out to hang and dry, because we are there to help you and to follow you through that. If we do a couple of days of Vicodin or oxycodone for a root canal or for a broken arm, you're not going to get redependent on that. You're not going to get addicted to that small amount. If you're on Suboxone and you take a certain amount of that, you might wonder, if I do oxy for breakthrough pain for an issue, does that mean I'm going to need more Suboxone later? You will not. That's not the case, especially when it's just a few days, okay? Another question that comes up is people ask me, what about going through withdrawals if I take pain medications on top of Suboxone? You will not get withdrawals when you take pain medication on top of Suboxone, okay? You will get severe withdrawals if you are on a bunch of opiates and then you brand new start taking buprenorphine, Suboxone. That direction, yes, you will suffer badly. You will get severe withdrawals, but not if you're already stable on Suboxone and then you add a pain pill like oxycodone or Vicodin through it, okay? You will not generally get the euphoria, but then again, we're not really looking for that anymore anyways. We're done with that part of the misuse of the medications, okay? So that part is really a non-issue because we're not looking for relief of depression, anxiety, addiction type stuff. The reason? Because we've already controlled it with the Suboxone. We've gotten it under control with that. That is the tool that's holding the main force of the dependency and the addiction under control. Everything else simply has to be done appropriately, as it does in every other patient. A lot of healthcare providers will approach me with this, and pharmacists too, and wonder why we are adding pain medicine on top of Suboxone. And what I've just talked to you about is the reasons that I have to explain to them. It takes a lot of education. A lot of them are just not aware of it because they're not. It's not that they're not educated, they're just not familiar with it, okay? It's a strange treatment protocol. They're getting better about it, but give them some slack if the pharmacist doesn't understand or they kind of worry about, hey, why are you being prescribed oxy when you're already on Suboxone? Just calmly tell them Dr. Edrich's got it in control. Just give him a call. He'll explain everything to you. Shoot me a text on our little inter-office texting system and tell me to call them. I will call them and gently re-educate them and help them understand. It's amazing how the pharmacists love that little bit of communication. They're oftentimes out in the dark, guys. They have no clue. They're still responsible, by the way, so when bad stuff happens with oxycodone, they get hit. They get hammered, okay? And that's not right. But they are responsible, so they have the right to worry and kind of freak out about controlled medications and opiates because they're on the hook for that too. So that little bit of extra communication that I provide to them by calling them and reassuring them, they love that. They really love that. All right, guys, hope that's been helpful as usual. What's really important is to just reach out and make that call. Give me a holler if you guys ever want to talk about this stuff. I always reassure people it's all about just having a conversation. You're never obligated to doing anything. Some people come in just say, hey, I've got a bad addiction to this, that, or the other. I'm not ready to do anything about it. I just want some information. If I choose to do something, what options would I have and how would you deal with that, okay? Non-judgmental, just get the job done. It's all about survival. It's all about finding proper pain management for people when they have pain issues. It's about proper depression, anxiety control when that's the reason they take opiates. Whatever it is, it's always about trying to find the proper underlying problem. You guys all do it in your jobs. I don't care if you're a plumber or an IT guy. All of our jobs are always the same. The electrician that comes to my house also says there's only one way to do this, and that's the proper way. So when you're interested, let me know. Job done for you properly, okay? Signing off. Talk to you guys soon. Bye.